Welcome, everybody. My name is Marty Mascari. I am a contractor under the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center, both of which are under the North Central Texas Council of Governments. We serve the greater Dallas-Fort Worth area in Texas. It's great to have you all on from all over the place. I know we have people, I saw one from the UK, all over Texas and especially all over the US. Welcome to everybody and Happy New Year. I want to start off by clarifying one thing, and I was just telling the doctor I didn't realize until we started doing this that there's bipolar 1 and bipolar 2. And so I have been educated. And so today we're going to cover bipolar 1. We won't be getting into bipolar 2 today. We'll figure out how to cover that later at some other time. But for today's purposes, I just want to make sure that's very clear because I don't want to be misleading. The flyer said bipolar. And so today we'll be covering bipolar 1. I did not realize there was two, number one, and number two, when the doctor got back with me, I realized that it would take two of these seminars really to cover both, and so today we'll cover the one. For those of you that are joining us for CEU units, we are set up to provide continuing education credits for licensed social workers and licensed professional counselors in the state of Texas. If you have a different license in Texas or you have a license outside of the state, you're more than welcome to go through the process, get a certificate, and submit it to your jurisdictions. But please note there's no guarantee that they will take that. I have had people tell me they've had them take that. I've had people even tell me that they've taken certificates of attendance, but that is up to your jurisdiction. We're also offering certificates of attendance. The rules or guidelines for both are the same. You must complete the entire webinar to be eligible. You must also complete the Google survey. The survey should pop up as you close out of Zoom today. If it doesn't, I realize companies and people have pop-up blockers. The survey link will be emailed to you in a follow-up email. And the next day or two, I am behind on those. I had a technical glitch, and so, but I should have those out by at least by Friday morning, if not before. The Google survey evaluation will be up for 1 week, and I will adjust that 18th out to whatever day, 7 days from when I get that follow-up email out to you. So it may be a little bit longer than the 18th, but it will be up for 1 week after I get that follow-up email out to y'all. And give me, and I don't know why I put the 118 there, give me till about 2:15, the February 15th to get those certificates out to you. If you don't get it by then, feel free to email me. Doctor, could we go to the next slide? So I want to introduce Dr. Modern. Dr. Modern is the executive director of the Modern Institute for Mind Body Wellness. He has 22 years of experience in in-person and worldwide virtual treatment in cognitive restructuring, behavioral modification, emotional regulation, and physical improvement. He's also the author of Mastering Character, Using Classical Skills to Build Character, and Living Well, a guide to cognitive behavioral skills exercise. And both of those are available on Amazon. If you put in Dr. Modern's name or one of those titles, you can get those, and I have both of them, and I highly recommend them. So I'm going to turn it over to you, Doctor, to talk to us about bipolar 1.
Okay, thank you. Glad to be here once again. Next time may be the last time. Hopefully not, but we'll see as we move forward. I've certainly enjoyed doing these. Today we do want to look at bipolar. There is bipolar 1 and bipolar 2. I'm not going to have enough time to cover both of those, although some of the features are similar for bipolar disorder just in general, so they overlap between 1 and 2. But we'll make that distinction. We'll look at bipolar 1. We'll look at some characteristics for bipolar 2. And then we want to just go through diagnostic features, associated features, prevalence, the development and course of it, risk and prognostic factors, sex and gender related diagnostic issues, association with suicidal thoughts and behavior, the functional consequences of bipolar 1 disorder, some comorbidities, some treatments that are out there, and then where people can find some support. Not only people with bipolar disorder, there's some support places for them, but also support for caregivers or people who work with those who are bipolar. So that's what we're going to look at. A lot of ground to cover today. I'll try to keep my reminiscences to a minimum as we move forward. Now, I know also, just to say up front, I know that it's also oftentimes sort of boring to go through the DSM characteristics and things like that, but some people get credit for this. They get some CEU, so we definitely want to do that. Also, remember that the DSM was really designed for clinicians to be able to talk to people across the world, right? So somebody in Austin can talk to somebody in Hamburg, Germany, and they'll say, well, look, I have a client who's experiencing these types of symptoms. These are sorts of the things that are going on. And somebody in the US can say, well, you know, I had someone who's experiencing the same thing. So over time, what we did was develop the DSM, where they came out and said, oh, well, we're calling that such and such, right? And for this case, we'd be calling it bipolar 1 disorder. But also what that allows us not only to name it, that's not so great, but it allows treatment to go on, right? So we found that in these cases, people who experience these sorts of symptoms, that this sort of treatment is beneficial for them. And so somebody in the US can talk to somebody in different countries. And so that's how the DSM is used best. Okay, there's a lot of misuse of it out there as well. But that's another reason we go through the diagnostic characteristics. Is so even people who aren't professionals, who just may be tuning in, who have some association with people who are struggling with bipolar disorder, that they can get a better picture of that and then see what most likely they're seeing, but also what other people across the world are seeing as well. So let's sort of distinguish between bipolar 1 and bipolar 2. Like I said, we're going to be looking at bipolar 1 today, but bipolar 1 is really the modern understanding of what used to be called manic depressive psychosis, or manic depressive disorder, or affective psychosis, all the same terms. But the old manic depression that you often hear if you watch old movies, sometimes you'll hear that used. That's sort of what we understand that to be bipolar 1. Now, bipolar 1 is characterized by mania, okay? Bipolar 2 doesn't have the mania. It has hypomania, and hypomania is, it lasts for a shorter period of time, and the symptoms aren't as bad, okay? They're not as severe in hypomania as they are in regular mania. So just as sort of a rule of thumb, when places I've been when we've had to work with individuals like this, you know, if they're presenting as manic, it's bipolar 1, because that's what it is. Hypomania is only going to occur for about 4 days. Mania is going to occur for at least a week, okay? And once again, the symptoms in hypomania are not nearly as bad as they are in mania. So if you're seeing the mania, then you know that it's bipolar 1. Now it gets a little more complicated than that, right? Because the manic symptoms may just not be to the point where they can get to. But there's some other things to look at as well. But bipolar 2, if you're seeing depression, and once again, this is sort of just a rule of thumb because you may see depression also in bipolar 1, but that's sort of you sort of think of bipolar 2 when you think of that. Once again, not a hard and fast rule, right? Because you may see that in both of them, but you're not going to see a whole lot of it in bipolar 1 that's not followed by or preceded by the mania. Okay, so in bipolar 1, neither the psychosis nor a lifetime prevalence of major depressive episode is a requirement for that. Once again, focus mainly on the mania, right? However, for the vast majority of individuals out there who have bipolar 1, all of those symptoms sort of present in that manic episode, when those occur, they're also accompanied by that major depressive episode during the course of their lives. So once again, even though you may be seeing depression, you have to sort of look at the whole picture, right? You can't say, well, okay, they're depressed, so this is bipolar 2. Not a hard and fast rule, right? You have to say, oh, well, they had a manic episode prior to that. Okay, well, then it's bipolar 1. Bipolar 2 requires the lifetime experience of at least one major depressive episode and one hypomanic episode, but no history of mania. If it's mania, it's full-blown mania, you're going to do bipolar 1. Bipolar 2 used to be thought to be less severe than bipolar 1. We don't think that anymore, simply because the depression itself causes serious impairments, work functioning, social functioning, these sorts of things. The depression itself is can be so severe, the consequences of that can be so severe that we don't distinguish between one or the other being more or less severe. Okay, so this is the diagnostic criteria, and I'm just sort of hitting the highlights here. There's a lot of things that I didn't cover. For example, I'm focusing mainly on adults here. There are characteristics for adolescents, for children in the DSM that you'll need to go back and look up. There's also all sorts of modifiers on these things, right? So if you're used to using the DSM and diagnosing and things like this, there's a lot of different modifiers for this. I didn't cover those. You'll have to go back to look those up yourself. These are just the big main points here. Once again, a lot of ground to cover. So let's get to it. For a diagnosis of bipolar 1, it's necessary to meet the following criteria for a manic episode. Once again, that's what characterizes bipolar 1 is mania. The manic episode may be preceded by or followed by a hypomanic or a major depressive episode. So like I was saying previously, I'm looking at something, it doesn't seem to be full-blown mania. Give it some time and see where it goes. Okay, is this hypomanic, or are we to the point for mania? Because that's often what happens. One of the biggest problems we have treating people with this disorder is that when they start to enter that sort of manic phase, they start to feel better, and they're not depressed anymore, and they start to feel better, and they stop taking their medication. They say, I don't need this anymore. I'm feeling a whole lot better. No, you need to stay on the medication. And let me just throw that in here just to dispel it. I was telling Marty before we started that Marty names these things, and I just fill them in. So he's a master at drumming up support. So he's, is there a cure for bipolar? Well, let's just take care of that right now. You're probably, for bipolar 1, at any rate, you're probably going to be on medication, if not your whole life, then for a very, very, very long time. Okay. So that's just something that presents. And this is one of the reasons that when people start to enter that manic phase, then they start to feel better, and then they stop the medication. And when they stop the medication, that's when they go off the deep end with the mania. Okay, I've seen this over and over again. So if someone has bipolar, then staying on the medication is the primary thing. There are other things we can do. We'll cover those other things when we get to the treatment part. But keeping them on their medication so that they don't go into a full manic episode is something we want to be aware of. Okay, so the characteristics of the manic episode itself. What are we talking about when we say mania versus hypomania? We'll look at the differences here. For the manic episode, we have a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy, lasting at least 1 week. Remember that for hypomania, it's only going to last about 4 days. If it lasts longer than 4 days, then we're looking at it moving into mania. It's present most of the day, nearly every day. If it's bad enough to get into the hospital, then any duration of hospitalization meets that criteria. During the period of mood disturbance and increased energy and activity, 3 or more of the following symptoms. 4 if the mood is only irritable. Another thing, let me go back right quick. When it talked about the mood, instead of that high, instead of being on a high and being expansive and all this other stuff, it may be irritable, and that's what you see often in children, adolescents. It's the mood is going to be irritable more than it is what you would normally think is that expansive mood and what have you. Okay, back to B. During this period, like I said, 3 or more of the symptoms, 4 if it's just irritable, are present to a significant degree and represent a noticeable change from the usual behavior. So we have that sort of baseline behavior. Somebody may just be normally expansive, right? But this is going to be more so. And that's what we're going to notice. Number 1, inflated self-esteem or grandiosity. And we'll look at some examples of this as we go forward as well. But that inflated self-esteem or grandiosity, once again, that manic stuff going on. A decreased need for sleep, may feel rested after only 3 hours, okay, which isn't once again characteristic in and of itself of things, but we want to look at it in a big picture, want to get a full representation of what's going on in these situations. More talkative than usual, or pressure to keep talking, flights of ideas, or subjective experience that the thoughts are racing, subjective experience, they may describe what's going on with them, have racing thoughts or what have you. In fact, that may become so prominent that the speech just becomes sort of nonsensical when you're trying to talk to them. They just have so much in there they want to get out, right? That's characteristic of the mania. Distractibility, for example, the attention is too easily drawn to unimportant or irrelevant external stimuli. And this can be either reported by someone else, so observed by someone else, or reported by the individual themselves. So easily distracted. Increase in goal-directed activity. Once again, got to look at the big picture. Some of these you're saying, well, I want people to have goal-directed activity, especially if you're a clinician, right? I'm trying to get people to have goal-directed activity. Well, let's look at this in the big picture once again. They have that goal-directed activity or psychomotor agitation, but it can be, for the goal direction, it's unreasonable goals. It's things that make really no sense given the person and who they are and all this other stuff. So yes, it's goal directed, but it's not realistic. So it's irrational goal directed activity. And then for the psychomotor agitation, it's not necessarily goal directed, but once again, it's just sort of purposeless stuff that's going on. What's the point in this? Why are you doing? There's no point in it. I just need to be doing something because I'm manic. Excessive involvement in activities that have a high potential for painful consequences. For example, in unrestrained buying sprees, okay, we often see that, sexual indiscretions, foolish business investments, and this often ties in, once again, this ties in with the other stuff, a good goal-directed activity. I'm going to start a side hustle, I'm going to start my own business, but it's with, raising snails to sell at escargot for, at restaurants. Yeah, okay, well, I may want to look at that. C, the mood disturbance is sufficiently severe to cause marked impairment in social occupational functioning that may require hospitalization in order to prevent harm to the individual or to others. Maybe psychotic features there. Remember psychosis, that sort of break with reality that we have. D, the episode is not attributable to the psychological effects of a substance. Okay, so always have to rule that out. And oftentimes substance abuse, those of you who may have worked with that or been around that, oftentimes doctors don't ask about that. They're getting better at it. There's over the years, there's been a move for them to get better at that. And I have noticed that they are getting better at it. But previously, and in some instances, they don't ask about that. So they'll go to oh, well, this must be some sort of bipolar. They're having a manic episode. No, they're just high. They're on meth. Which can meet several of those criteria that we just looked at, right? Something like that. So making sure, got to rule out that they're not on a drug of abuse or a medication, right? I mean, it doesn't have to be a drug of abuse. It can be a prescribed medication, some other treatment that they're getting that's causing that. Note a full manic episode that emerges during antidepressant treatment, for example, the medication or electroconvulsive therapy, but persists at a fully syndromal level beyond the physiological effect of that treatment is sufficient evidence for a manic episode. So even though they may be on antidepressant treatment, okay, but the episode continues, and you're seeing those strong symptoms of this, okay? It's not hypomania, but we're seeing these symptoms are really pronounced and what have you. May want to look at that in itself fulfilling one of the criteria for the bipolar 1 diagnosis. Okay, so that was the mania, right? We have to have that for bipolar 1. But remember, it may be preceded or followed by either a hypomanic episode or a depressive episode. So we want to look at hypomanic episodes here and what those look like as different from the manic episode itself. So a distinct period of abnormally and persistently elevated, expansive, or irritable mood, but that's only going to last for 4 consecutive days. Okay, once again, for the mania, you've got it for a week, right? You're seeing a week of it. And if it's actually mania, what you may see is at 4 days, it may look hypomanic, but by the time we're getting to beyond that, that's when it's really starting to look manic. Things just don't happen on a snap, right? You just don't go from being depressed to being manic like that. So there may be a charging episode as it goes forward on that, where they're charging up for the mania. During the period of mood disturbance and increased energy, 3 or more. Once again, very similar to the manic. What we're looking at is the time and the strength of these. How strongly are these things presenting themselves? Inflated self-esteem or grandiosity, once again, decreased need for sleep, more talking than usual, flight of ideas, distractibility, increase in that sort of purposeless goal-directed activity. And by purposeless, once again, I mean, it's irrational, right? Is it goal-directed? Yes, but it's just irrational. It's not something that they're ever going to pull off, right? That's sort of what happens. Or the psychomotor agitation, which itself serves no purpose. Once again, excessive involvement in the activities that have a high potential for painful consequences, sex, spending, foolish business investments, these sorts of things. Once again, very similar to the manic, but they don't last as long. They're not as pronounced, okay? So you want to watch. If they've been going on for 4 consecutive days, I want to watch. Is this going to start tapering off now, or is this continuing to increase? Is this still there? So that's going to tell me the difference. The episode is associated with an unequivocal change in functioning that is uncharacteristic of the individual when they're not symptomatic. So when they're in that period where they're not hypomanic, they're not manic, they're not hypomanic, they're not depressed. When they're in that period, we have that sort of baseline functioning, right? Once again, you see that sort of baseline, but we start to notice that this is the hypomanic when it's not the same as when they're on the baseline. The disturbance in mood and change in function are observable by other people. So it's not just subjectively reported by them, but people can see that this is going on. And that's really what you see in treatment, right? You see somebody who's, they don't tell you that they stopped taking their meds, but you notice that, things are changing. This is not normal. This is not what's usual here. So you do see that going on. You can observe those things, and it's severe enough to cause you to notice that, but it's not necessarily severe enough to cause the same kind of marked impairment in the social and occupational function that you see in the mania. So once again, this is sort of the, when we talk about the strength of the symptoms, the presentation of the symptoms themselves aren't nearly as strong. In the mania, they're going to cause marked impairment in social and occupational functioning, may necessitate hospitalization. In the hypomania, you're going to notice the difference once again, but it's not going to be enough to cause problems in social and occupational functioning, and then nobody's really looking at hospitalizing them at that point. Okay, and the episode is not attributable to the physiological effects of a substance. Once again, always have to rule that out. Just over the years, working with people who did have substance use disorders, and talking to them and seeing what, they would go to the doctor, they would get all sorts of diagnoses, bipolar and what have you, and you would ask him if they were using and things like that, and then, oh yeah, I was using at the time. So you don't see it in residential treatment, something like that. You're not seeing the same thing. How did you get this diagnosis? Well, I was using meth at the time. I was using coke. I was something give me this manic sort of appearance, and nobody ever asked if I was using drugs. So like I said, they get much better these days about asking those sorts of things. There's a major movement in the medical community to make sure that they did, and the good ones always did, but some of them didn't. But they've made that effort, so I'm seeing that a whole lot more these days. But make sure you rule that out. Okay. Note a full hypomanic episode that emerges during. This is sort of the same thing. If they're on antidepressant treatment, something like that, but the symptoms persist at a level beyond the physiological effect of the treatment, is sufficient evidence to call it a hypomanic episode. Just caution there that one or two symptoms, particularly increased irritability, edginess, or agitation following antidepressant use, are not taken as that sufficient diagnosis, because those may be the side effects of coming off of the antidepressant, right? So you don't want to be diagnosing something that is in the normal course of it. As I'm coming off of the antidepressant treatment, that may make me more agitated, that may make me more irritable. So that in and of itself, you don't want to use. Okay. Now we get into the major depressive episode, which is pretty much a major depressive episode, right? But once again, we may see this either before or after the manic episode. So 5 or more of the following symptoms have been present during the same 2-week period and represent a change from the previous functioning. So things are changing. That's what we're noting. And at least one of the symptoms is either a depressed mood or a loss of interest or pleasure. So this major depressive episode is what we're looking at here. So you're going to have to, one of the symptoms is depressed mood or a loss of interest or pleasure, some anhedonia that's going on there. Okay. Once again, don't include symptoms that are clearly attributable to another medical condition. So if they've got something else going on, you're going to have to rule some things out as you go forward. So the first one, depressed mood. You got to have that for most of the day, nearly every day, as indicated by either their subjective report. They're saying, I feel sad, I feel empty, I feel hopeless, or somebody else can observe that. They appear tearful in these situations, and so we could look at that being a criteria. Once again, children and adolescents, oftentimes this is going to be what presents itself. This is going to be what shows up, is that irritable mood. Number 2, markedly diminished interest or pleasure in all or most all activities, most of the day, nearly every day, once again, either by their own account or somebody can observe what's going on. Those are the two that, one or the other of those two needs to be present for this to meet the major depressive episode category in bipolar 1. Significant weight loss when they're not dieting, okay, or weight gain. So we're looking at it as a change of more than 5% of body weight in a month's time. Okay, so that's significant weight loss or weight gain, or decrease or increase in appetite nearly every day. Okay, now in children as they're developing, once again, the whole diagnosing children sort of thing is, anyway. We're not really looking at those, but in children, you may consider a failure to make expected. So in their development, they're going to expect children to gain weight at a certain progression. Well, that may not be happening, or it may be happening too much, right? So that's what we want to look at there. Also present in this are the insomnia or hypersomnia nearly every day. Okay, nearly every day you're seeing that go on. Psychomotor agitation or retardation nearly every day. Okay, so they're either acting or not acting, right? They're agitated or that emotion is stopped, and that's observable by others and not merely what the individual themselves is reporting. Okay, so we see them agitated, or they move at a normal rate and they're not doing that anymore. Okay, so that's what we can check that one off based on observation of what's being observed. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive or inappropriate guilt, which may be delusional, right? May have no basis in fact whatsoever, may just be delusion. And that happens nearly every day. And it can include, but it's not limited to, self-reproach or guilt about being sick, right? So that may indeed happen. Diminished ability to think or concentrate, some indecisiveness that's going on, once again, nearly every day, their report or observed by others. And then recurrent thoughts of death, not just a fear of dying, okay, that fear of dying would be healthy, right? But recurrent thoughts of death, recurrent suicidal ideation, without a specific plan, or a suicide attempt with a specific plan, okay? So those are the characteristics that you'll see for that. The symptoms cause clinically significant distress or impairment, social, occupational, or other important areas of functioning. Once again, sometimes people can just have a bad day, or have a bad several days, okay? Doesn't necessarily mean we're going to give them a diagnosis for that. So we want to see, is this really causing problems in somebody's life, right? What's going on here? Let's look at, is there clinically significant distress, okay, that's going on in their lives, social, occupational, educational, somewhere in these. The episode is not attributable to the physiological effects of a substance or another medical condition, okay? So definitely want to see those. Note A through C is the criteria for a major depressive episode, right? So we definitely see that. Major depressive episodes are common in one, but aren't required for the diagnosis of it. It could be hypomania as well. Remember, one, we're seeing mania, okay? Maybe preceded or followed by hypomania or depression, major depressive episode, but we're looking at the mania is what it is for bipolar 1. Okay. Response to a significant loss, such as bereavement, financial ruin, a lot of people with FTX, maybe losses from a natural disaster, serious medical illness or disability. You have those things go on. You have those feelings of intense sadness. You ruminate about the loss, have insomnia, poor appetite, weight loss, et cetera, although they're understandable when those things occur. It may be that major depressive episode may be in addition to the normal response to a significant loss. So don't just say, these things have gone on, so I'm just going to dismiss this criteria. Okay, so people have the weight loss, ruminating about loss, intense sadness, insomnia, these sorts of things. But they had someone close to them just died, so we're going to rule those out. Not necessarily. Okay, need to watch those. Need to get the big picture on that. See if stages of grief are being followed, what have you, if they're working through these things. If they're not, maybe something else going on. Once again, just clinical judgment, looking at the individual's history, and what have you. Cultural norms, some of that, the expression of distress in the context of the loss. They may have lost a parent or something, but may not be, may have been estranged or something like this. So once again, you want that big picture when you're looking at this. You want a clear understanding of what's going on all the way around, not just in one little area. Okay, this is not, there are some things in the DSM that are very easy. This is going on, this is what we have. You don't necessarily have to have a big picture. You can see these sorts of things and just sort of check those boxes off. Other things, we need a bigger picture. We need to see what's really going on in the individual's life as we move forward. Okay. The mood in a manic episode is often described as euphoric, excessively cheerful, high, or feeling on top of the world. Okay. Once again, this is why this makes it difficult to treat, because people start feeling that way and they say, I'm feeling great, I don't need to take any more medication, and they stop doing it. And guess where that leads them? Not into a good place, I can tell you that. So we don't want them to feel bad, obviously, but at the same time, is this excessively cheerful? Okay. In some of these cases, the mood is such of a highly infectious nature that you come away feeling like that yourself. Oh, well, wait a minute, what's going on here? And sometimes that's how you'll pick it up, right? That you yourself may come away from that. So that's what you want to look for, right? It's easily recognized as excessive and may be characterized by unlimited and haphazard enthusiasm for, once again, interpersonal, sexual, or occupational interactions. The individual is so expanded, right? Is so cheerful. I just stop people on the sidewalk and start, engaging in conversation, start to talk to them. Now, let me say, once again, got to have the big picture. My grandfather used to be a very sociable individual. He was not bipolar. This was not a problem with him, but he was just a very friendly person. And, it's one of those people who've never met a stranger, right? He would go someplace and come away, but he'd never go someplace he'd never been before and come away with, new friends when he left. So got to look at that big picture. Is this normal for this person, or is this just sort of an isolated thing that we can recognize this manic episode? That's what's going on. Often the predominant mood is irritable, once again, rather than elevated, particularly when the individual's wishes are denied. Okay, so we see that somebody isn't getting what they want. That's something else that we see in treatment. That people, and when they come into group or what have you, they'll talk about it. About what's going on at home, and oftentimes that's when you'll pick some of this stuff up, right? My spouse or whatever, denying my wishes on this, and they become very irritable and things like that. Or if they've been using substances. So once again, want to always rule that out. Okay, have you been using? Okay, so let me get a picture of what's going on with you here. May need to give them a UA, right? They need to give them a urinalysis to find out whether they actually have or not. But if that's not going on, then you're looking at that really expansive mood. You may have rapid shifts in mood over brief periods of time. These occur, and that's referred to as lability, right? They have your little check boxes that you have. If somebody comes into the psych hospital and you're checking these things off, That's the mood is labile, right? That's what that is, labile, moving back and forth from one to the other. They go from euphoria to irritability to dysphoria. Everything's great, nothing's great. I'm upset about it, whichever way it is. So that rapid shifting, going back and forth, is often a diagnostic feature of what's going on. The inflated self-esteem is typically present in the mania, ranging from uncritical self-confidence to marked grandiosity, and may even reach delusional proportions, right? That's criterion B1 that we looked at. Once again, I recall a man who was bipolar. He was diagnosed with bipolar. He was also a musician. And he used to walk into, when he was in his manic episode, he would walk into a hotel and expect people to treat him like, he was the Rolling Stones or he was George Strait or somebody. He wasn't a bad musician, but, nobody knew who he was. Okay. Even South by Southwest. I mean, he was just he was all right, but he wasn't anything but he thought he was, right, when he was in this manic episode, and expected to be treated that way at hotels and when he would go in and things like that. So that sort of grandiosity, that uncritical self-confidence, that I'm going to go in and talk to the Rolling Stones who may be in town or something like that, or South by Southwest. I'm going to go talk to them and set up something with them, and they don't know who you are. It's irrational, right? It's unreasonable to think that these things. That's what you're looking for, that sort of irrationality. Despite a lack of any particular experience or talent, right, the individual may embark on complex tasks, writing a novel, seeking publicity for some impractical invention. Okay, now I just finished a novella, so I took that off, but I have. My undergraduate degree was in English, so I have written some things over the years, not only academic but also for entertainment, for the slicks and things like that. So if I say, well, I'm going to write a novel, that's not out of the realm of possibility, right? But somebody who never made it past 8th grade, well, I'm going to write a novel, and it's going to be a novel about my life and my experiences. Okay, well, it may be good, right? And I don't know, you may find a ghostwriter to do that, but you're probably not going to do it. So that's sort of, off the cuff there, sort of out of the norm. The impractical inventions are those, you see those often. Anytime somebody says they have created a perpetual motion machine, right? That's okay, let's check that box. Let's see what's going on. You're on your medication and what have you. So these sorts of things. And once again, these are out of the norm, right? I mean, if you have somebody who is an inventor or something like that, I mean, it may not be out of the norm for them to actually do that. But for individuals who, with bipolar 1, this is out of the norm for them. They may be writers, right? They may be writers. So then they decide to write a novel. Okay, all right, that's great. But this is going to be out of the norm for them. They've never liked writing, number one. They can't write very well, number two. So this sort of thing is what you're looking at. These grandiose delusions, especially something like, I have a special relationship to a famous person. Larry Gatlin signed my cowboy hat at an AAA meeting that I went to one time, and so I'm going to go talk to him, and we're going to get back on the road, and this sort of thing. Once again, that's unreasonable, sort of irrational sort of thing that goes on. The increase in goal-directed activities, criterion B6, that consists of excessive planning and participation in multiple activities, which may include the sexual, occupational, political, or religious activities. So once again, as clinicians, you often want your people to be goal-directed, right? You want them to set goals, but they need to be reasonable goals. They can't be these goals that require 50 steps, having somebody sit down and really do, as those of you who practice know, that oftentimes having them sit down and plan these things out. What's step one? What's step two? What's step three? And they've never even thought of it. They have no idea. It's just some pie in the sky sort of thing that they have. So it's not really, in that respect, it's not really goal directed. Or maybe it is goal directed, but they have no plan to get there, no realistic plan to get there, that sort of thing, or involved in 50 different things at once, right? Trying to make them all work. Also, you may see an increased sexual drive, fantasies, and behavior when it goes into the mania. So these sorts of things, now they're Casanova, right? They're Don Juan, which some people may be true. Once again, we want to look at it as irrational. For this particular person, it's out of the norm. Okay, that's what. Once again, when I look at that big picture, when I get an idea of what's really going on here. Okay, you can't. It's really difficult. This is one of those things where you have to have a, almost a 360-degree picture of what's going on in somebody's life. Otherwise, you risk. They may be Don Juan, right? They may be the next Stephen King or what it is. Even though they've never done it before, it doesn't mean they don't have the background for it. So you have to really look at the history, really look at what's going on with them, and make sure that it's if it's irrational, then it's irrational. But if there's something to it, then we can't use that as sort of a diagnostic feature. And that's why you really have to get into this before that bipolar 1 diagnosis is made. Individuals with a manic episode usually show increased sociability. Once again, renew old acquaintances. I hadn't seen him for 15 years. Oh, I think I'll give him a call, right? Calling or contacting friends or strangers, at odd times and things like that. Or once again, somebody I haven't talked to for a very long time. Now, once again, doesn't mean that I won't do that, right? Oh, I just happened to think of, some guy I knew that I used to work with. I wonder what he's doing now. Okay, well, that's not unreasonable, right? Is it unreasonable? Is it irrational based on the norm for this person in that normal period? But they're not manic, they're not depressed, they're not hypomanic. In that normal period, is this something that they would normally do? Is this something that's going on? If not, okay, well then we're seeing sort of this symptomology here. They often display psychomotor agitation or restlessness, once again, and it's purposeless, has no purpose for it. I mean, if I'm doing something repeatedly and it has purpose is one thing. If it has no purpose, then that's a symptom. It may be pacing, holding multiple conversations simultaneously. My wife does that, drives me crazy. She's not bipolar, but she'll be talking and say something. I'm like, what are you talking about? Well, I'm talking to the person on the other end of the phone. Well, choose one of us. Don't talk to both of us because it drives me crazy. But like I said, not going to diagnose that there. But this person maybe have more than two people, right? Maybe talking to 3 or 4 people at the same time, trying to balance all those things. And in their mind, they can balance it, right? There was a drug commercial, a pharmaceutical commercial on for something, I don't remember which one it was, but it's something for the bipolar. And that's where you see the individuals doing 50 things at once, right? That's sort of what this is, right? It was a good depiction of that, whatever that commercial was. I haven't seen it for a while. I don't remember what it was, but it was for bipolar. So the individuals write excessive letters, emails, text messages, so forth, on many different topics to friends, public figures, the media, once again, engaged in 50 different things at once because my opinion needs to be out there because I can solve this problem. And, once again, the mania. And some people, maybe polymaths, they may be able to do that. But have they been doing it before and been doing it successfully? Or is this just something that's, that comes up when somebody's not on their medication or when the manic episode kicks in? So is it rational? What's the history of it? What is the norm? Is it a deviation from their normal behavior? They're not manic, they're not depressed, or hypomanic. Okay, and then the expansive mood, excessive optimism, poor judgment often lead to reckless involvement. Once again, these are sort of the, not only these, but these are sort of the types of things you see. The spending sprees, okay? Giving away possessions, reckless driving, foolish business investments, right? Investing in that snail farm for the escargot, right? That I'm going to make contracts um, uh, with kitchens in Houston and Dallas and all over Austin, and I'm going to make a fortune selling snails. Okay, don't don't laugh. I've seen it. Once again, the sexual indiscretions that are unusual for the individual. Once again, looking at what is the norm, and then does this deviate from what we're seeing in the norm? And all of these, even though the consequences may be catastrophic to them financially or personally or what have you, interpersonally. Okay, so these are some associated features that we see with bipolar. During a manic episode, individuals often don't perceive that they are ill or in need of treatment and vehemently resist efforts to be treated. Talked about this. This is the biggest hurdle to a consistent treatment, is that they start to feel good. They're entering that sort of, manic rise, and they start to feel good, and they don't need any treatment for this. They don't need to take their medications, so they stop. Okay, over and over, I've seen that happen, and I'm sure those of you who treat this have as well. So this is a major thing. Individuals may change their dress, makeup, or personal appearance to be more sexually suggestive or to have a more flamboyant style. Once again, that would go with the sexual indiscretion and what have you. Some people perceive a sharper sense of smell, hearing, or vision. That's a subjective experience, but they may report that. Gambling, antisocial behaviors may accompany the manic episode. Next presentation, I believe we're looking at the differences and similarities between borderline personality and bipolar. And there's a good reason that we're doing that. And it may have to be with antisocial, some of the antisocial person behaviors that pop up during both of these. The mood may shift from very rapidly angry to depressed. Some individuals may become hostile, physical, threatening. And when they're delusional, they actually may become physically assaultive to others or suicidal themselves. Serious consequences of a manic episode, such as involuntary hospitalization, difficulties with the law, serious financial difficulties, often result from poor judgment, loss of insight, and hyperactivity. These are three things that you want to pay attention to: poor judgment, loss of insight, hyperactivity. If you're seeing those, that should ring a bell. Depressive symptoms occur in some 35% of the manic episodes, and mixed features are associated with poor outcomes and increased suicide attempts. So when you have the manic episodes, 35% of those will also show those depressive symptoms. And these sorts of things, when we're mixing those features, you're going to have a poor outcome in treatment and may see increased in suicide attempts as well. Bipolar 1 is associated with decrement in quality of life and well-being. This used to be thought, that's what made this so worse than bipolar 2, right? But bipolar 2 has that as well. So we don't no longer say that one is worse than 2. They're both bad. Trait-like features associated with the diagnosis include hyperthymic, depressive, cyclothymic, anxious, irritable temperaments. So once again, we can see not only expansive, but also the irritable stuff going on. Sleep and circadian rhythm disturbances, may only sleep 3 hours a night, right? Reward sensitivity and creativity going on. Having a first-degree relative with bipolar increases the risk of that diagnosis approximately 10 times. Okay, so if you've got a first-degree relative with bipolar disorder, not necessarily bipolar 1, but with bipolar disorder, okay, this includes 2 as well, or cyclothymia, then you may see an increased risk of diagnosis of tenfold. Okay. The prevalence of bipolar in society, a 12-month prevalence of DSM-5 bipolar 1 disorder. And the reason this says that this way is because remember, we're now in DSM-5 TR, okay, the text revisions. But this was, and so there are some changes in the diagnosis between revisions of this. So this was DSM-5 criteria. It was a nationally representative U.S. adult sample, was 1.5%. So what's the prevalence? About 1.5%. Not a whole lot of difference between men, which were 1.6%, and women who are 1.5%. So it occurs just about equally in men and women. Compared with non-Hispanic whites, prevalence of bipolar 1 appears to be higher among Native Americans and lower among African Americans, Hispanic, and Asian Pacific Islanders. So, so a little bit higher among other cultural populations. The 12-month prevalence of DSM-5 across 11 countries, so now expanding it sort of across the world, not only the US, ranged from none to 0.6. So 1.5 is double that at least in the US, but it was greater in higher income countries than lower and middle income countries, except Japan, where the prevalence was very low. It was 0.01%, and they're a high income country. So the lifetime prevalence ratio to men to women is 1.1 to 1. Okay, so very similar between men and women. We see that show up. The peak age of onset of bipolar 1 across studies is about 20 to 30 years old, but remember, it can occur throughout the lifestyle. We have to look at children and adults as well. But normally about 20 to 30 years. In the US, the mean age of onset is 22. It's 21.5 for women and 23 for men. So it occurs a little sooner, a couple of years sooner for women than it does in men. But the mean is about 22 there. In a comparison of 6 international sites, the median age for the DSM-4 TR, okay, which was at the DSM-4 TR, DSM-5, now we're on DSM-5 TR, was 24.3 years. So looking at it across the world, about 24.3 years, 22 in the US. More than 90% of the individuals who have a single manic episode go on to have recurrent mood episodes. So it's usually not just one. It's usually, once they have one, we're going to see more of them. Approximately 60% of the manic episodes occur immediately before a major depressive episode. So once again, if you're seeing that major depressive episode, you gotta pay attention. Is it just a major depressive episode? Is that the diagnosis, or is it hypomania, or which would be bipolar 2, or is this occurring immediately? We got to watch if it occurs immediately after this. We're going to have that manic episode, which occurs before the depressive episode afterwards. Individuals with bipolar 1 disorder have multiple, which is 4 or more, mood episodes, which may include the major depressive, manic, or hypomanic, occurring in the prior 12 months, receive the specifier with rapid cycling. So a lot of specifiers there. Once again, not going to cover all of them, but oftentimes we talk about rapid cycling bipolar, which means they move between major depressive, manic, and hypomanic at least multiple times, 4 or more in the past 12 months. That's the rapid cycling. And that's a common variant associated with poor outcomes. So the more rapid cycling, then the poorer the prognosis for that is. The course of bipolar 1 is very heterogeneous. However, we have some patterns have been noted across episodes. The polarity of the first episode tends to be associated with predominant polarity of future episodes and with clinical features. Depressive onset is associated with greater density of depressive episodes and suicidal behavior. So what shows up, manic or depressive, it's probably gonna stick with whatever how it showed up as it goes through its course back and forth. The presence of mixed features in a manic episode is associated with poor prognosis, poor lithium response, which is one of the treatments for bipolar, and with suicidal behavior. So those mixed features in that manic episode, poor prognosis, as we said before. The risk factors that we want to look at, childhood adversity, including emotional trauma, if a parent has it, parental psychopathology, family conflict, all of these are known risk factors for bipolar and tend to predispose to early onset of bipolar disorder, not necessarily 1, but 1 and 2, just bipolar disorder in general. More recent life stress and other negative life events, since a depressive relapse causes a depressive relapse risk. So life stress, not good, increases the likelihood of a depression relapse. Manic relapse appears to be specifically linked to goal attainment life events, getting married, getting a degree, all these high stress things, okay? But they're high stress in that they're goal attainment things. Cannabis and other substance use is associated with the exacerbation of manic symptoms in individuals diagnosed with bipolar, not 1 or 2, but just bipolar, both, as well as first onset of manic symptoms in the general population. So, don't do drugs. Just say no. Okay, bad things can come out of that. Seen that happen as well. There's some evidence that that becoming married is less common among individuals with bipolar disorder than in the general population. So they have bipolar disorder, less likely to get married. And also, the diagnosis of bipolar disorder is associated with being previously as opposed to currently married. So if you were married, it's maybe common that you're divorced, okay, is what that means, right? The diagnosis of bipolar is associated with being divorced. Genetic and physiological risk factors. Once again, the heritable predisposition to bipolar is around 90% in some twin studies that they've done. So you had twins, looked at those, around 90%. The risk of bipolar disorder in the general population is around 1%, while the risk in first-hand relatives is that 5 to 10%. We talked about the 10% before, but it goes between 5 and 10%. The mechanisms of that heritability is non-Mendelian, which means it's not simple. Okay, it involves multiple genes or just more complex genetic interactions, small effects that have small effects interacting with each other, the environment, and or other random factors. So what that says is a clear link to genetics. We know that it's there simply because we see 90% of twin studies, 10%, general population with first degree relatives. So we think there's something there, but how exactly that works out is not straightforward at all. Certainly there are environmental factors in that, can't rule those out. Other random factors we don't know anything about that may be influencing these things. How the genetics associated with this and other genetic predispositions, how those interact with each other, we just don't know. Okay, it's unclear at this point. Sex and gender related diagnostic issues. Women may be more likely to experience the rapid cycling, once again, 4 more episodes within a 12-month period, and mixed states, and have patterns of comorbidity that differ from those in men, including lifetime eating disorders. You see those in men. Those in women more than men. Women with bipolar 1 or 2 are more likely to experience the depressive symptoms than are men. Women with a higher lifetime risk of alcohol use disorder. So women have a higher lifetime risk of alcohol use disorder than do men, and a much greater likelihood of AUD than do women in the general population. So if you have that diagnosis of bipolar, then your risk of alcohol use disorder is going to go up. Some women with a bipolar disorder, either 1 or 2, experience exacerbation of symptoms and severe emotional disturbance during premenstrual periods, during perimenopause. It can get worse during these times, especially when estrogen levels go down. There appears to be no increase in mood disturbance during pregnancy for women who continue on their medications. When you get off your medications, something different. But so even though you may see it in premenstrual and perimenopause, you're not going to see that during pregnancy as long as they stay on their medication. Lifetime risk of suicide in individuals with bipolar is estimated to be 20 to, yeah, that says the same thing, doesn't it? That may be something different, 22 something fold greater than the general population. I have to look that back up, 22, I want to say 20 to 40. I don't know that that's true, however. Typo. An estimated 5 to 6% of individuals with bipolar die by suicide. So that's quite a bit, 5 to 6%. While suicide attempts are higher in women, lethal suicide is higher in men with bipolar disorder. I don't know that that's much different from what we see in suicide in general. Nearly 50% of individuals whose symptoms meet the criteria for bipolar, either 1 or 2, also have an alcohol use disorder. Before we talk specifically about women, but this includes men as well, 50% of individuals who meet the criteria for bipolar have an alcohol use disorder. And those with both borderline and alcohol use disorder at a greater risk for suicide or attempted suicide or suicide death. Okay, functional consequences of bipolar 1. Approximately 30% of individuals, boy, you know, when I type my fingers, I'm always surprised at, it's almost like my hands don't know what my hands are acting of their own accord as I type this. But 30% of individuals with bipolar 1 show severe impairment in their work role functioning. So once again, that occupational functioning, that's where we're going to see some severe impairment with that. Although remember, many return to a fully functional level between episodes. Okay, so that norm, they're functioning normally, right? But once they start to move into the manic part of that or the depressive part, we're going to see a major occupational functioning hazard going on. Functional recovery tends to lag behind the recovery from symptoms. So even if they look better, then that doesn't mean that they are better. There may be, especially when you're talking about the occupational recovery. So we have that functional recovery once again is gonna lag. The symptoms aren't there, but don't expect everything to get better just because the symptoms are better immediately. So there's going to be some lag on that. And because of that, that results in lower socioeconomic status. Even though the education levels are the same with other people, right? Compared with the general population, then we're going to see lower socioeconomic status because of that lag and just the time it takes to get back up to normal. Excuse me. Cognitive impairment persists throughout the lifespan. So there's some impairment in the thinking throughout the lifespan, even during the euthymic periods when, you know, they're not manic, they're not depressed, they're just even. And that may contribute to vocational and interpersonal difficulties. Higher levels of self-perceived stigma are also associated with lower levels of functioning. So some self-prophecy often goes on in these things, right? So I'm been diagnosed as bipolar. I see myself as bipolar. So I have a lower level of functioning because I just know that. The comorbidity on this, co-occurring mental disorders are the norm in bipolar 1, and the majority of individuals have a history of 3 or more disorders, okay? So 3 or more. Most frequent comorbid disorders are anxiety disorders, alcohol use disorder, we just looked at that, and other substance use disorders, and ADHD, okay? These are the most common ones that we see going on. It is frequently associated with borderline, okay? Schizotypal and antisocial personality disorder. So when we saw the presentation of those sort of antisocial features, yeah, we can see that. In particular, although the underlying nature of the relationship between bipolar and borderline is unclear, preview for next time, the substantial comorbidity between the two reflects some similarity in the phenomenology of it, that is, how they are perceived and how they are diagnosed. So, so there are very much similarities between these two that show up in the presentation of these symptoms. And like I said, I believe that's our next presentation is bipolar and borderline, how those are similar and different. Individuals with bipolar 1 often have high rates of serious co-occurring and untreated medical conditions. The comorbidities appear in multiple organ systems, and being comorbidly overweight or obese is particularly concerning for individuals with bipolar, period. Okay, treatment. What do we get here? Medications, okay, yes. We definitely need medications. There may be continued treatment that goes on. So once again, probably once you start those medications, you may be on those medications for a while. Okay. There are day treatment programs that people can go to. You may need substance abuse treatment because once again, alcohol use disorder, very prominent. Other substance use disorder can be as well. So that may be what's going on. Some attempt at self-medication here that occurs. Hospitalization maybe. So some of those hospitalization, especially during the mania, right, when you're having that manic episode, that may get you into the involuntary admission into the hospital. The primary treatments for bipolar include medications, psychological counseling to control the symptoms of it, and also education, support groups, things like that. The psychotherapy is not going to have much of a chance to work if people are off of their medications. I'm not saying that it can't do that. Everybody's different, right? There's a lot of heterogeneity in how these things appear. They appear a little different for everybody and what works for everybody. But in general, if you're heading toward the mania, then skills are just going to sort of go out the window, okay? Because you're not going to think you need to use them. A skill is something that you use, right? So if I don't think I need to use it, I'm not going to, and that's the problem. Medications, different mood stabilizers. I have listed these here. You can get the slides and see these. Lamictal is often used, Depakote, these sorts of things are common ones that I've seen. Antipsychotics, okay. If these, especially the mania, but also the depression, if those symptoms persist in spite of other treatments, you may go to these antipsychotics, and these are not good, people. These are not good. Risperdal, Seroquel. Now, people who use Seroquel, I often think I need to invest in that company, because I used to be in a treatment facility. When someone would come in and say, we can't, the psychiatrist would not prescribe them Seroquel. He said, no, we can find something else. Let's use Lamictal or Depakote, something like this. Try a mood stabilizer, get you off of the antipsychotic. And boy, those people on Seroquel, they were fought to not give that stuff up. They fought to keep it. Let me tell you, more than anything else that I ever saw. Okay, so people, nobody likes to give up what they're used to and things like that, especially if they've had a long time of trying to find out what works for them. But the Seroquel was one that they'd fight you tooth and nail to hold on to that stuff. But anyway, so the antipsychotics, those do not have good side effects. Okay, long-term use of those will you will develop tardive dyskinesia. Okay, and tardive dyskinesia, to just give you an example of how prevalent the use of antipsychotics is that now when you're watching television, guess what you're going to see? They're going to have a commercial on there for treatment for tardive dyskinesia. So they prescribed these antipsychotics so much that the tardive dyskinesia has become a significant problem. Now they're selling you the cure to the problem that they created. So antidepressants, once again, antidepressant or antipsychotic things going on. Anti-anxiety medications, so benzos, once again, benzos are highly addictive. Okay, anything you can do with skills you want to do, but like I said, it's very difficult if they get off of their medications, if they get off of what's working for them, then you know, skills are limited in their use at that point. Not that they're of no use, but they're limited in their use. It'll depend on how much the individual wants to use them and how severe the symptoms are. There are different kinds of psychotherapy out there. Interpersonal and social rhythm therapy is one. Remember, we talked about the sleeping can be off, the circadian rhythms can be off, these sorts of things. Interpersonal and social rhythm therapy is really creating a routine, a structure for somebody to follow. This is easy to see. This is a good one because as we create this structure, if someone starts to deviate from that structure, that should be cause for concern, right? So we have this structure, we know the structure works, and then they deviate one way or the other from that. We know something's going on at that point. Cognitive behavioral therapy, certainly cognitive behavioral skills that we have, those can help with different things. Reality therapy has been used to treat this as well. So it's a cognitive behavioral therapy, but those can be useful as well, those skills. Psychoeducation, just learning about the disorder, learning that you do not stop your medication. Okay, learning about how good you feel. You do not stop your medication without telling somebody. Number one, just stopping the medication can have side effects which can be deadly. Okay, so number one, no, you don't want to do that. And then number two, you most certainly, if you're going to do it, if you talk to your doctor about it, he's probably going to say no, which is why people just quit, right? But at the same time, just knowing that if you do that, that maybe what you're feeling is because of the medication, you're feeling better. So continue what you're doing, what's working for you, instead of changing your direction, and changing horses in midstream. Family-focused therapy, family support communication can often help people stick with a treatment plan. Once again, family is somebody who can see if you have that structure going on, if you change your structure, they can pick up on that pretty easily, even though you may not be able to, individual may not be able to. Family can see that and tell you, you're getting out of your lane, what's going on here, and so they can bring that to your attention. So those are good things. Support, if you want support, here's some. VP Hope is one. That's a good support group for bipolar. The Depression and Bipolar Support Alliance is out there. There's a link to that right there. That also includes a support group locator based on zip code, so you can put in your zip code, find out the closest one to you. NAMI, National Alliance on Mental Health, there's their 800 number. Also, you have their link there to their website. If you are caring for someone with bipolar, there's some challenge and support tips from Psych Central. You can go to there. Healthy Place has a bipolar caregiver guide. Okay, so you can look at that. And then the place you really want to go with a lot of useful information for you is Bipolar Caregivers. and their link is there. Okay. I think that's it. I think I've ran through that to the point where I sounded like I was having a flight of ideas.
Great stuff. Here's Dr. Modern's contact information, but I'll also include that in the follow-up email as well. You know, our next webinar is bipolar versus borderline personality disorder. And just to reiterate what you said, and that'll be on the 25th. But the other thing is we'll have to work on one for the top 783 things to consider when you're considering opening up your snail farm in Texas. And so we'll work on that and try to get something going. But
let me just give you a hint. You want to consider fire ants. Personal experience.
Okay, so let's go back to the CEUs just for a bit. Okay, so the doctor's looking over what your comments and questions are. I'm going to run through this again for those of you that are joining us today for continuing education credits. Please understand that we're set up for licensed social workers and licensed professional counselors in the state of Texas. If you have a different license in Texas, or you have a license outside of Texas, you're more than welcome to go through the process, get the certificate submitted to your jurisdiction. But please know that these are the only two jurisdictions we are set up with that we could help you with if there seems to be a problem with them accepting it. I've had a lot of people tell me that they've used the certificates for other places, but that again is up to them. You could also get a certificate of attendance if you'd like. We also have those. For joining us today, it is good for 1.5 hours of CEU credits. In order to qualify for those, you must have completed the entire webinar, and you must have done that live. You must complete the Google survey evaluation form. It should pop up as you close out of Zoom. But if it doesn't, you'll receive that link in a follow-up email. I may not get those out to Friday morning. I've had a technical issue and I'm behind on those. And the technical issue has with registration for some of the other events. You should have that by Friday. I will adjust the length of time that is up for 1 week from the time I get that follow-up email out to you all. So if I don't get out till Friday, I'll adjust it a couple of days. Give me till, and I screwed that up. Give me until about the 15th of February to get those certificates to you. If you don't get them by then, feel free to reach out to me. But please understand, I don't really try to address a lot. I get a lot of questions about the process of getting CEUs from people. You know, if you're on here, we go over that twice. And if you're on here to get CEUs, I kind of expect that you're paying attention enough to understand the process while you're on here and not have to ask me those questions offline. I'm a one-person operation. I've only got so much bandwidth here, and so please know that I'm expecting you to follow this. If you have something in the chat, I'm more than welcome to help you with that. But for emails of how to get the CEUs after the fact, that's not something I usually respond to, just because I kind of expect that you've been online and listened to what we've had to say. So, Doctor, I'm going to turn it over to you to answer any questions.
Okay, we have a question about what are some of the common symptoms of mania. So those were covered on there. You can look up the slides, which are available to you. I'm not going to go back over those. Another one, do patients with bipolar mania but believe they really have ADHD and want treatment for that? Can the two be coexisting? Remember, they are comorbid. They can be comorbid. So that's one of the common ones that you see is bipolar and ADHD. So that ADHD can be comorbid with the bipolar. They can have both of them, right? Remember that you may have 3 or more, right, is common. So diagnoses going on. So not only the bipolar, but also several others as well. And ADHD is one of the common ones that show up. There's some good suggestions for some books in here that people may want to look at. Are meds safe during pregnancy? Talk to your primary care physician, right? That would be who you would want to talk to about that. I wonder if women aren't significantly affected more during pregnancy because of the stem cells from the fetus acting as a protection. Curious about that statistic. All these statistics came from the DSM-5TR. So if you're interested in where the research on that is, you might check there, and you can follow that back to where they got it from. Why would they fight to stay on Seroquel? Sleep. Okay. The thing that I heard most often in those arguments was nothing else helps me sleep. So that's the one I heard most often. Yeah, very sedating. Yeah, exactly, Michelle. Yeah, that's what I was hearing. Could they stay on antipsychotic? Long-term use, what's considered long-term use? If a patient doesn't have any side effects, could they stay on antipsychotics if it works? I'm not suggesting that you get off of it out of consultation with your psychiatrist, right? But if you read when you go to the pharmacy and get those, read the side effects on there, okay? And of course, if you read the side effects on a bottle of aspirin, you might be sort of hesitant to take those as well. But especially antipsychotics, we've known for many years, at least 20 years, of the very harmful side effects that can go on this. If you're not having side effects, then don't worry about it. But we tend to see these things more often than not. Let's see. Okay, sorry, we had no cure for you. No longer want Aletha. That's right. You tell me you do not want a Snell farm. But if you do, make sure you protect them against fire ants. Okay. Is DSM-5 clear about that? I would have to go back and look at DSM-5 on this to answer it there. Looking at differences between bipolar 1 and schizoaffective. Remember that one of the things I did not cover, simply for time restraints on it, was differential diagnosis. Okay, in the DSM-5TR under bipolar 1, it has a very long section on differential diagnosis. So schizoaffective may actually be in that. I can't recall right off the top of my head. Certainly schizotypal is associated with it, but I'm not sure about schizoaffective. But there is a differential diagnosis section, which I did not cover just due to time. Okay, I think that's it. The question, I didn't look at questions and answers. No. Is bipolar 2 a prelude to bipolar 1? No. It doesn't necessarily progress from one to the other. What you'll see is bipolar 1 that you may have the presentation of major depressive disorder, but then you'll have the mania that'll come on. The mania from ADHD can be, is it easy to distinguish? You're not going to, when you see somebody in mania, a manic phase in bipolar, you're not going to forget that. Okay, so yeah. So, worked with people with ADHD, and certainly they have, they can have some stuff going on with them, but it's very different from bipolar 1, the manic episode. What do you recommend if a client discloses they're no longer taking medication for bipolar disorder and don't desire to take it anymore, and you've been seeing and counseling for 3 weeks? You're limited by your disclosures. you're limited on what you can do for that simply because it's if they're your client. Then if you're working in a treatment team, if you can get them to sign a disclosure where you can talk to their psychiatrist or talk to their primary care physician, whoever it is that's providing medication, then do that. I would try to get them to sign a release of information. They should have signed one when they first started, just simply so you can talk to the doctors and what have you. If for some reason that was missed, try to get them to sign it. Otherwise, you're sort of limited. Just focus on those skills. Focus on that skill thing, and they may have to be, that would be my biggest recommendation right there. Would be try to get them to sign a release so you can talk to the prescribing physician, and then let the doctor know that they're off of it, so you can bring more pressure to bear on that. Okay, thank you.
Very good. And just so in regards to the CEUs, you can use this. We just give you the certificates. You have to go to the jurisdiction and work with them on whether they'll take it or not. There's no reason why you can't submit it to more than one jurisdiction. But again, it's up to them whether they take it or not. If you have problems with the 2 licenses that we work with in Texas, you're more than welcome to reach out to me because we're set up with those. But the other ones, once again, it's up to them. So number one, we talked about bipolar disorder and borderline personality disorder that we're doing next. I want to make sure you understand that's the last webinar, at least in the foreseeable future, that Dr. Moderns is going to be able to do for us, because he's got something else coming into his life that's going to take up his time. I want you all to know that he has donated all of his time over the last 2 years to do these for us. And we are so grateful. I mean, we are so grateful to you, Doctor, for all you've done. It is just incredible. And as you know, by all the feedback, we have phenomenal response to him. But thank you so much. Once again, he has donated all of his time. He does not get paid for doing this, and we are very, very grateful. Thank you so much.
My pleasure.
And we'll see you again in a couple of weeks. Y'all join us for that. And once again, we'll get this recording up and have it available to you all as well. Take care.